We are very excited to welcome Dr. Ben Curtis as our speaker. The lecture this evening is titled Frenectomies with an All-Tissue Laser. This is part one of a two-part series focused on this important topic. Tonight, Dr. Curtis will be discussing indications and techniques for frenectomies in newborns. Part two will be on Thursday, March 5th, with a focus on adolescents. So if you're joining us this evening, please, I'll tell you how to find us for March 5th, but we'd love to see you join us on March 5th as well. As always, we are hosting tonight's webinar on the Zoom platform and welcome your questions during the lecture in the Q&A feature in the lower toolbar of your screen. So we've already been chatting a little bit, learning about where everyone's coming from. That's the chat tool. Right next to it, you'll see Q&A. That's where we want you to post your questions as Dr. Curtis is lecturing this evening. And we'll wrap up with a few minutes to address those questions at the end. Let's Talk Dental is our new webinar series with a focus on a diverse range of topics relevant to today's dental community. In addition to Dr. Curtis's two-part series on frenectomies, we also have several more webinars lined up in March, one on myofunctional therapy and the other on billing and coding tips. So you can find more information about these webinars at our education website at education.biolase.com. At the conclusion of the lecture and Q&A session, I will provide information about BioLase Education's CE process, so you do get one CE for joining us, along with additional web resources you can access to continue your learning journey in the exciting world of laser dentistry, including upcoming courses you may want to consider, so I will highlight a few courses. Tonight's webinar is being recorded. So as you're watching and you think, oh, I wish I could see this again, you can. Go to education.biolase.com and our webinar library is there where you can watch this, including all sorts of other webinars we've recorded through the years. With that, let me formally introduce our speaker. Born and raised in Wills Point, Texas, Dr. Ben Curtis was inspired to become a pediatric dentist after the poor dental experiences he had as a child. He strives to make dental visits fun for kids by providing gentle, compassionate care. Dr. Curtis graduated from Texas A&M University with a Bachelor of Science in Biomedical Science and a minor in business. He attended Baylor College of Dentistry, where he was awarded his doctorate of dental surgery. Remaining at Baylor, he completed his rigorous pediatric dentistry training. Dr. Curtis and his wife, Rachel, are proud parents to Birdie, Dodson, Emerson, and Goldie. And Dr. Curtis owns his own practice there in Canton, Texas, Curtis Kids Dentistry, as you see in the background there, right outside of Dallas. So Dr. Curtis, super excited to have you with us this evening. I think it's your turn to take the mic, sir.
All right, guys, thank y'all for joining me. And no matter where you're coming from this evening, I hope we're going to have a good time together and we're going to learn about a really awesome part of pediatric dentistry or just dentistry in general, where we're looking at taking care of infants, a very unique little niche within the world of what we take care of, but a really, really important one. So thanks for tuning in and let's get started. We got lots to cover. We're going to run through this pretty quick and we'll be trying to take some questions at the end too, okay? All right, guys, here we go. All right, who am I? I'm a father. These are my four kiddos. All right, we got Birdie, Dodson, Emerson, and Goldie. So those are my pride and joy and my sweet wife, Rachel. When we're not at home on the farm with our bovine friends, we are normally, you can catch us at Disney. We were just there for the Christmas party last year, so we shut it down a couple of times there. So we rocked and rolled there. So it's always a fun time. Did my dental school at Baylor. This is one of my buddies from dental school. You'll notice here on injection day, he hit the money and I cured him from giving injections to anyone else. He's an orthodontist now. I had the great pleasure to stay at Mother Baylor for my residency, and here are some of my awesome co-residents that are now all over the world. So we are family and friends. I'm a diplomat to the board. I love this picture of Laurie. She's the past president for the board. Her and I lectured at the ski meeting. This was in Vail during COVID, so we all masked up there. Had a great time there. Speaking of the ski meeting, I am the past president of the Southwestern Society of Pediatric Dentistry. We put on an awesome ski meeting every year. If you haven't attended, you should look into it. It's going to be in Snowmass next year. This year, we just had it this month, and it was in Big Sky. So we took our oldest kiddos, and we had an awesome time. I was a Harris Fellow for the AAPD, and I did my Harris Fellowship on advocacy for children across the nation. And my program chair for that fellowship project was the late great Dr. Susie Seal. And from her, I have been so inspired to teach and really know that, education can open up doors that you never thought were possible. And so I give her a huge shout out every time. May she rest in peace. I have a private practice. So I worked in Dallas for so many years, and then I moved back home out to East Texas, and I am in the small town of Canton, Texas, out here in the middle of East Texas. We are a rural community, but right on the street from my office, literally like 2 miles away, is this cannon mounted on the back of this gun called the Cavity Creator. They fire this sucker off multiple times a day, and at Halloween they shoot candy from it, and it rains candy. It's insane. So we are not just battling tongue ties out here in East Texas. We are battling candy rain. Our carries risk is ridiculously high. I do a lot of education for BioLace and for many things. And so I spoke at the Greater New York meeting in New York City this last November. I spoke at the ski meeting just in Big Sky. Spoke at AAPD year before. I'll be at AAPD Toronto. So if you're there, look me up. I got 2 courses there for that. I do large lectures, in-office trainings, webinars, all sorts of stuff. And there's lots of past resources for you available on BioLace Education website. So these webinars are recorded and they're available for you there. So don't forget that. If there's something that you're looking for, I've probably done a webinar for you. Okay. If you have not gone and signed up for Tequila and Tongue Tie, I'm going to need you at 8 o'clock when we get done to go and sign up for Tequila and Tongue Tie Miami. It's going to be epic. It's probably going to sell out ridiculously because it's going to be a good time. There's a great lineup, some awesome speakers, and we'll have some more details for you after that. This is our 3rd annual Tequila and Tongue Tie, and so we need to see you in Miami. Full disclosure, I am provided for you by BioLace. I work for them in educational type things and stuff. I'm providing lectures just like this for you. Without the support of BioLace, lectures like this would not be possible. So thank you, Joe, and our educational team at BioLace for making these webinars possible for you this evening. A few things we're going to touch on. We're going to identify some indications for frenectomies in infants. We're going to utilize some pre-op and post-op assessment tools to be able to really make sure that we're helping to identify the symptoms of not just the baby, but also the mother as well. And then we're going to walk through step-by-step techniques. That's going to take us a while. So we're going to fly through a lot of this just to make sure we can get you that understanding of all of those sorts of things there. As Joe said, this is a 2-part series. We're going to focus on infants tonight, and then we're going to focus on kind of children and adolescents in our next talk in May. So make sure to tune in for that. All right. So first off, why do we care about a tongue tie? Okay, let's focus on this for a little bit. Let's look at this sweet baby. This baby lives in my community here in East Texas. And the before picture is how they came to me. All right. This baby was the 3rd baby, not the first one. Mom had 2 other babies, breastfed them like champs. This one struggled out of the gate, just not right. Mom couldn't latch. Baby had to go to NICU for a couple days, struggled with bottle feeding, struggled with breastfeeding, literally blew up like a balloon, just like you're seeing, bloated horribly after every feeding, fed every 2 hours. This went on for over a month. And then finally we were able to get to the baby to do a tongue tie release. And this is what the baby looked like literally right after the procedure, after we did the tongue tie release, and they no longer bloated, no longer had these issues, and was able to feed, gain weight, and do great. This baby was literally a day or so away from a feeding tube and being hospitalized, and within 24 hours afterwards had no more of the symptoms. That is not every baby in America, but what I want you to appreciate is that these babies live out there. This is not a fad. This is real. And this was life changing, not just for this baby, but for this family and for the community we live in. And so I want you to think about the effects that you can have by treating infants aren't just related to helping that baby, but they help the mom, they help the family, and they help make sure that that child is heard, is felt, and it's taken care of. Your impact is going to be far more reaching than just one simple procedure. So buckle up. Here we go. All right. I love quotes, and Benjamin Franklin's one of my favorites. If you haven't read the autobiography of Benjamin Franklin, you're missing out, guys. Go check in on that. One of the quotes from his is, "Without continual growth and progress, such words as improvement, achievement, and success have no meaning." We must continually grow and continually to push that progress forward. Okay. Well done is better than well said. We're not just going to talk about it, we're going to take action. Okay. We are about action. First, let's talk about like what's going on with the tongue. Okay, what is the tongue? It is a very, very crazy muscle. Okay, that muscle just floats in your mouth and it is attached to hardly any bone at all. It's attached mostly to other muscles by fascial planes. Okay, all other muscles in the body function based upon bony attachments. All right, your bicep attaches to bone, it makes a function. Okay, everything else has bony attachments. This tongue functions so much differently. So it's very, very unique in the way that it functions and moves. What is it evolved in? Of course, digestion. Okay. A little later on in development, it's involved in speech, respiratory, tongue up, lips closed, healthy breathing through your nose. Thank you, Dr. Zaghi at the Breathe Institute. Growth and development. If that tongue doesn't apply the right pressures, bone grows based upon where the muscle pushes it. All right. So if we don't have proper musculature, muscle pressures, muscle pulls, then we're not going to be able to have proper growth and development. Okay. But one thing we always tend to forget about is quality of life. Okay. And we'll touch on that more next time we talk, as far as things like eating, like an ice cream cone or kissing. Okay. If your tongue isn't working right, guess what? None of the rest of that is working. Okay. What is a tongue tie? All right. When we're thinking about it, we want to think, what is the tongue supposed to be doing in there? The tongue should be able to move around and function. So if we're having impaired mobility, where the tongue can't go from side to side, up and out, then we're going to have restricted mobility. We're going to have restricted function to those sorts of things. And out of those restrictions in those and impairments in that, it can affect thus the digestion, the speech, the airway, the growth, all of those sorts of things. And we're going to dive a little bit more into kind of this nebulous anterior posterior ties as well. Okay. One of the big concepts we're going to focus on through this series is this right here. All right. When we're looking at identifying a concrete foundation to call a tongue tie indication, we must establish symptoms and provide solid symptomatic documentation. We must apply functional issues. Okay. We must be able to document those. We must be able to describe the anatomy. Okay. And put those three together to thus indicate a procedure. Okay. Just like anytime you diagnose caries, you're going to have a description for that. You're going to have a radiographic description. You're going to have a clinical description, a symptomatic description, and you're going to put all those together to indicate your treatment that you're going to recommend. Same thing here. We must document those things and put it in place. So we're going to work through that and how we're going to do that. What is a frenectomy? Okay. Simplistically, all right. I like to keep things simple. All right. In simplicity form, what we're doing is we're taking and moving the tongue up and the floor of the mouth down. You're literally just filleting the tongue off the floor of the mouth. Okay. You make an incision and send the tongue up and the salivary glands downward. Okay. We'll walk you through that in a little bit. What are the frenoms? You can't just tell me that you have a restricted frenum. There are so many frenoms in your body and in your mouth. We need to identify anatomically which ones those are. The lingual frenum, all right? For our documentation purposes, we're not calling it a tongue tie. We're calling it a lingual frenum. You've got a superior labial or a maxillary frenum, an inferior labial or a mandibular frenum, okay? You've got buccal frenums. We got to make sure we're talking about the right thing. But what exactly is this tissue, okay? This tissue is not just a fold of buccal mucosa. For the longest time, that was our understanding of what this was. But there's more to it than just that. It's actually the buccal mucosa plus the underlying tight fascial attachments. This landmark article came to us out of Nikki Mills out of New Zealand. She published that in Clinical Anatomy. Dr. Mills is a world-renowned anatomist, okay? And she published this article back in 2019. Before 2019, our understanding of what a frenum was just a buccal fold of mucosa, okay, under the tongue or in the lip. But this article showed to us that we don't just need to be releasing the buccal fold of mucosa, okay? You need to be releasing the underlying fascial attachments. And we'll walk through what that is, okay? But that's an important concept. We've released the buccal mucosa and we are releasing these underlying fascial attachments, okay? Let's dive a little bit into history for infants, okay? I mean, we've breastfed babies for all of civilization, okay? For all of mankind, babies have been breastfed up until recent years. When I think about Frenectomies, I think about Maya Angelou, and this is one of my favorite quotes. You do the best you can until you can do better. And when you know better, do better. We were all trained to be the best doctors we can be. But what if there were better ways of doing it, better ways of handling it, better ways of treating it? Then wouldn't we know better and then do better? So let's do better. You're going to see by the end of this, there's a better way of doing this, okay? Old school, think medieval times. Goodness gracious, babies had to breastfeed or they wouldn't make it. We didn't have bottles back then, right? And so babies had to have tongue releases. This is nothing new, okay? Third world country survival, midwives that deliver babies. There's a thing where they have a sharpened pinky nail that slices the tongue and slices the lip. Village doctors in third world villages release tongue ties and release the tissue under the tongue readily so that the baby can feed. That's part of their normal assessment. I served patients in a very international community in the Dallas region of Dallas, Texas, and we had patients that came to us from all over the world. And I had one family in particular I'll never forget that was an African family that had recently immigrated to America, and they had their baby here in America. There was no issues with the baby at all, no feeding issues, nothing like that. But they brought their baby to us because we were known for treating tongue ties, and they wanted the baby to be having a tongue release. There were no feeding issues, no anatomical issues. Like literally, the assessment was null and void. Like there were no indications, but the parents were very adamant they wanted that done. And I asked them why. They were so confused why we made them jump through all these hoops to try to prove that their baby needed a tongue tie. Because within their culture, back in third world Africa, where they had come from, that was a normal thing within their civilization, within their culture, within their place and time to have their baby's tongue released immediately at birth. And for them, that was their standard of care. But coming to America, it was much different. That was a very eye-opening conversation to have to these sorts of things that we in America have forgotten about in our first world problems. Okay. The big pendulum swing from breast to bottle, now back to breast. Okay. Bottles really took off in the 1900s into the 50s and really replaced breastfeeding almost exclusively until the 90s, where breastfeeding really started to become more popular again. And then in the 2000s, it really became more of the breast is best recommendation. So it's really been within the last 25 years that we've really seen a major swing back over into breastfeeding. And now we're meeting all of these complications that for generations have gone undiagnosed or not a problem because of bottle feeding. Okay. What do the healthcare authorities have to say on that? Okay. Well, our AAPD, the American Academy of Pediatric Dentistries, okay, they're the big authority on little teeth. I have a little quorum with that. Should we be the big authority on little mouths? We own the whole mouth, right? Not just the teeth. We're not tooth doctors. We're oral care physicians, okay? They recommend that exclusive breastfeeding for the first 6 months and then continuing with feeding for the first year. I would call that the American standard. Most American families would probably goal to achieve that. Okay. What about the World Health Organization? They're supposed to be the expert on health for the entire world. They recommend breastfeeding until 2 years or beyond. Okay. So what's the problem here? Okay, we want to walk through what sorts of signs and symptoms we might be having. And this is where the two-part series happens. Okay, we've got infant symptoms and then we've got child and adult symptoms. And today we're going to stay on that side of the continental divide, on the infants. Okay, we have to look at age specifics. Okay, and we're going to break this down today into infants and babies. So under 6 months and 6 to 12 months. One of the things I want us to focus on is if we're going to be working with infants, okay, we want to make sure we have a good resource for them like lactation consultants, okay? It is so much better for that baby to have a tongue tie and lip tie release in conjunction with a lactation consultant if we're looking at issues for breastfeeding. If we're looking with issues for feeding, we want to make sure we have a good speech feeding therapist on board as well. The team approach is what's going to get us there. You own the mouth. So I always like to say, even if you're not going to be the treating provider, that doesn't mean you can't be an advocate for that child and refer them to a proper place for care. You are there to help. Okay. Let's focus in on the babies. Feeding problems. Oh man, this is something that we see particularly between the 0 to 3 months, okay, where the baby won't latch, or the baby was latching for the first month and now is starting to struggle again. The baby won't get a deep latch, they slide off. The baby's exceedingly gassy and bloats and is so fussy, like we saw in that baby in the picture. They click, they smack, they leak from the corners of the mouth. They're frustrated during feeding, they're frustrated afterwards. These are a long list of things that we see that definitely matter. One of the biggest things of all that matters to the pediatrician is their ability to gain weight. I had a baby today that the mom was so frustrated because the pediatrician wouldn't help her with these oral ties because the baby kept gaining weight. And so the mom and the baby are struggling. The baby just won't stop crying. The baby cries all the time. But the pediatrician isn't really nodding any efforts over to that because the baby is gaining weight. So in their book, the baby's fine. Okay. So knowing that there's more to the story than just did your baby gain weight. Let's take into fact maternal symptoms. Okay. The number one thing that we need to have on our radar is maternal nipple pain with latching and feeding. Okay. Other things that can happen are lip blisters, crack blisters, lipstick shaped blisters, abscesses, and mastitis. Okay. You can have a heavy flow or you can have a slow flow. We can be dealing with exhaustion, anxiety, and postpartum depression. We want to acknowledge that the mother is an active part in this process just as much as the baby is for this under 6 month, and that she may be exceedingly fragile, and you can be an advocate for her as well. She's juggling a lot, she's dealing with a lot, and she may be navigating waters she never thought she'd be navigating. But that maternal nipple pain is one of the number one things we want to be talking about and focusing and documenting. There is one research article out there that talks about an anterior attached tongue, basically meaning it's attached to the tip, and severe maternal nipple pain is an indication for a release of a tongue tie. So if we can establish maternal nipple pain and an anterior attached tongue, you've got an instant path for success for your indication. Let's say once we make it through that, okay, through that first 6 month process, now we start to introduce baby foods. We have a lot of parents that where the pediatrician has helped them limp along, where, okay, well, you're gaining weight, it's a little bit sluggish, we're struggling, bottles are a little sloppy, breastfeeding is not going so well, but we're making it, we're making it, we're making it, we're struggling, we're pushing through. Let's get to baby foods and then we're going to be good. But what if that's not the case? What if we get to these purees and now it's just as bad, sloppy, and a struggle? Okay. We see that where these babies are struggling with foods, solid foods, purees. They're choking. They're having to swallow. They're just spitting it back out. They're gagging. They can handle purees, but not the textures. And so these can be big things that we want to make sure that we're discussing in that 6 to 12 month age range. And one of our biggest concerns is they're gaining, gaining, gaining. Now they flat. Okay. We see these babies that were doing okay. We were limping them along, but now we're trying to transition over to foods and they're stop gaining weight. Okay. Then the pediatrician starts to become concerned again. And so we want to make sure that we're helping them with that. Okay. I can remember several babies that I've had that will only drink formula bottles that are 12 months. They've never been able to work on actually swallowing. I have one baby I'm working with, a feeding therapist right now. So how do we, this is a lot to go through. How do we know what to ask? Okay. If this is all the things we need to be thinking about, geez, that's a lot to think about in a short appointment time. And how do we document all of that? I mean, that's a lot to go through. Okay. Your answer, a questionnaire. Okay. Isn't that what we all needed was another piece of paperwork to add to what we're doing? So we're going to work smarter, not harder, so that we can help that mom be able to get all of her questions and all of her symptoms documented. Okay. So in this, we're going to have the parent fill it out ahead of time before they get there. Okay. That's going to make it so much easier for the mom. So if you have the ability to email or text her the form, then you want to do that. Okay. Have her fill it out. That way, when I walk in the room, I don't walk in the room without my questionnaire. Well, where do you get this from? Okay. This doesn't just a pin out of thin air. All right. Thank you, Dr. Richard Baxter. All right. He wrote the book Tongue Tied. All right. He's the Alabama Tongue Tie Clinic, and he has online resources free to you for doctors. And you can go on his website and you can actually download these forms, and they're edible PDFs. So you can go and edit them for how you want. Okay. He's got infant specific ones. Okay. He's got child specific ones. And then you can actually edit those for yourself, for your office. And what we do is we've made these into Weave forms. We use Weave, the platform Weave, and we actually can text these to the parents. They can fill it out on their phone and send it right back to us. Okay. It is beautiful. All right. And then the staff can just print this out for me. So I have it in my hand. When I go into the room, I'm able to show the mom everything she filled out. We just shred the paper afterwards. It's a beautiful process. It makes it where I can talk about the points they checked on really quickly. And as opposed to spending like 2 hours talking about all this, we can knock it out in like 10 to 15. These questionnaires are really, really helpful. Okay. Other really important pre-op documentation is going to be intraoral pictures. You would never do a filling without having an x-ray. So I never want you to dive into doing a frenectomy without taking a pre-op photo. Okay. So we need to document symptoms. We need to take a picture. We need to describe the anatomy in the note. We'll walk through that. We need to have a classification for that frenem. So like, what does it look like? How are you describing it? I need to be able to picture that in my mind based upon your documentations. Okay. We'll walk through that. So let's look at this assessment tool. What's all in here? Okay. One of the big things I want us to focus on is looking at, is the child, were they vaginal? Were they C-section? Were there complications? If there were complications at birth and it was emergent C-section, that baby may have had a very traumatic birth, okay? And we may need to be involving individuals like a chiropractor to help us work through maybe tightness and stuff. I had one baby that broke a clavicle, okay? And that took them months to get over. And so it was really difficult for feeding on one side because that's where the broken clavicle was. Vitamin K. We want to make sure that we're documenting vitamin K, and we'll circle back to that in a minute, okay? Other surgeries, all right? We'll talk about that in a minute. Common infantile surgeries. So vitamin K. So pretty much every baby that's born in a birthing institution, so like a hospital, is recommended and gets vitamin K. You have to sign to refuse vitamin K. But if you're delivered with a midwife, or if you're delivered in a home birth, or you're delivered in a birthing house by midwives, then most likely you were not receiving a vitamin K unless you elected into it. At the hospital, you have to sign things to elect out of it, okay? Vitamin K is a coagulation factor. Within 24 hours of getting vitamin K, your factors go up, all right? And so you have a much higher coagulation abilities. If you don't have vitamin K, it takes several months to build up that coagulation. So you just want to know and document if the baby's had vitamin K or not, okay? And we don't have time to talk through all of that vitamin K at the minute, but definitely we want to make sure that we're documenting it and we're knowing proceeding forward the pros and cons if we don't have it, okay? Common infant circumcisions. Males, circumcisions for males is exceedingly high in America. And so every little boy that I'm doing a frenectomy on, I'm asking if they were circumcised. If you had a circumcision and it went well, you're probably going to have a frenectomy that goes well. Okay, so that's a really good indicator for how they're going to do. And the parents can easily correlate those together. And honestly, it gives them a lot more peace of mind. You can't do that with the females, but for the males, it really tends to help the parents be more at ease by actually communicating that. So I talk about circumcisions all the time, okay? It's an easily understandable thing. Let's talk about symptoms a little bit more. What are some common ones that I look for? Clicking and smacking. I would say almost 95% of babies that come to me that have feeding issues have this clicking, smacking, like sucking air from the corners of their mouth. And definitely that's one of the big concerns for the parents. And definitely it leaks in air and helps to cause them to have more GI issues. Okay. The lip curls under. Okay. The lip goes under versus being that Instagrammable duck face. Okay. That is a telltale sign and a struggle about a lip tie. Okay. The passy falls out. Your baby either likes to take a passy or they don't like to take a passy. If they want to take a passy, but they can't take a passy, red flag. Okay. And so if the parent has to hold, like I was looking at, if the parent has their finger in the baby's passy, holding it, red flag. Okay. That's because the tongue is pushing the passy out versus pushing the passy up to the roof of the mouth. Okay. Definitely some common red flags that you will see a lot if you're asking those questions and easy things to talk about. Breastfeeding, okay? You may not have ever breastfed. I have never breastfed, okay? And so I am very forward with my patients that I am not your breastfeeding expert. I am your surgeon and your anatomical expert, okay? It's really important that if we want to have successful breastfeeding, that we're working with a breastfeeding expert, aka an IBCLC or a lactation consultant, okay? But we want to understand that with breastfeeding, that it's important to have a good latch, a good deep latch. The lips need to be flipped out. The tongue needs to be able to hold and move the breast tissue up. That we want to have good kind of suction around the area, not overusing the lips, and that we don't want to be having a lot of leaking from the corners of the mouth. If we're having any alterations in that, we want to be working through why, okay? One of the big things when we're talking about infants and we're talking about breastfeeding, you have to be prepared to have breasts in the office that are shown and open and around. Okay. And so that's definitely something that you want to make sure that you feel comfortable with and that we are not discouraging, but we are just helping a mom along her breastfeeding journey. You may not have thought about that if we haven't necessarily ventured into that, but definitely that's something that we may want to be talking to our staff and our team about. Okay. In our office, we are a free breastfeeding office where you can free breastfeed open and anywhere. So if you want to breastfeed in the waiting room, cool. I'm not going to discourage you. If you want to breastfeed while you're walking around in the back waiting on your other kids, we will not discourage you. If some other parent has a problem with it, we'll move them into another area. But we are very supportive and open with our families with breastfeeding. I normally, with a mom that is breastfeeding, the staff lets me know that she's breastfeeding. And if I need to go in the room with her, we'll have a staff member come in. Normally, I wait for her to finish breastfeeding and then I come in the room. In my East Texas area, moms are a lot more comfortable breastfeeding by themselves and then me coming in the room. Okay. So that just tends to be how I handle that in my office. But definitely, we are an open, supportive breastfeeding office. Okay. And if you're going to be doing a lot of infant frenectomies or encouraging that within your office, you just need to make sure that your staff, your team, and you yourself are prepared for that. One of the biggest things I want us to think about is this lip, okay? We normally think about the tongue, but I want us to think about this lip that rolls under, that is calloused, that is a struggle. I did a really good Instagram and Facebook post. I'll give you my information for my social media handles there, but documenting what those look like. So I want you to go there to my Instagram and look that up after the talk, and you can see what I'm talking about with these lips and the struggle with that. Okay. So we just want to be thinking about that. For our young age, that's definitely can make feeding an issue. As we get older, it can cause some other issues. Okay. We want to be thinking about the mother. And one of the big things we want to think about is her maternal pain, as we talked about, and we want to document it. Okay. Some of these moms don't have any issues at all, and others is horrendous. I've had one baby that has so many struggles, okay, that they were actually coughing up or spitting up blood, and that was not their blood, that was the mother's blood from her cracked bleeding nipples, okay. And so I don't say that to be macabre or to be disturbing. I say that because it's real. That is real life. Those are things that parents struggle with and that we need to be aware of, because it's one thing just to have maternal nipple pain, okay, but it's another thing to have maternal nipple pain. Okay, we need to be talking about it. We don't need to be sweeping it under the rug, which is what normally happens at the pediatrician's offices. Okay, we have to take into account both the baby and the mom's symptoms and their issues when we're dealing with maternal breastfeeding and we're dealing with babies and infants. Okay, let's move on into the clinical exam. So that's kind of what we're looking at, symptoms and how we're documenting that and working through it. Let's work through our kind of age appropriate clinical exams. Once again, tonight we're going to focus on babies, but the next time we come together, we'll focus on children and adolescents. Once again, I need you to tell me in your clinical exam what frenum it is you're talking about, okay? For our clinical exam, I like to stand over the baby at 12 o'clock, okay? In a normal exam room, you can go through and have the doctor sit here at 12 o'clock and the assistant help hold or the mom help hold, and you can look at the baby over the top of them. In my office, I have a lactation room where we have a changing table, and I will stand right here over it, and the parent can stand here next to me, okay? That way they can see at the same time I can see. In our lactation room, we have two rocking chairs, one for mom, one for dad or other spouse, or grandma who may come. In our patient population, we have a lot of grandmas that come and support. Okay. And so just knowing that you want to be able to have yourself set up for success, but looking over the baby, you do not want to do this in a car seat carrier. You want to have the baby out. I like to have them in my lap so I can see. Okay. You want to take pictures. I take them on my iPhone and upload them into the patient chart. Okay. The iPhone is great because you can edit it, you can make it move around, you can crop it and make it a nice pretty picture. Okay. We want to make sure that we're documenting in the chart also our anatomical or clinical findings. Okay. Is it attached all the way to the anterior tip of the tongue, like this top one or the middle one? Or is it more in the middle or posterior where it's way in the back? Do we have this classic Eiffel Tower look where the salivary glands are getting pulled up with it? One of the big things I like to document and think about is this finger sweep barrier. So how severe is the tightness when I rub my finger under the tongue? We want to make sure that we're describing these things, we're documenting these things. Here's that kind of classic Eiffel Tower. Once you see it, you can't unsee it, but normally the salivary glands are buried in the middle. Once again, in a nutshell, our frenectomy is to release the tongue from the floor of the mouth, and the salivary glands reside in the floor of the mouth. Okay. Another thing that I like to do and that you'll want to do is actually put your finger, pad of your finger up into the baby's mouth and have them suck on it. You'd be surprised how many babies are like they can't suck on your finger. And I instantly ask the mom, like, do they gag like this when they're nursing? Is this a normal thing for them? Okay. Are they able to move your finger around and hold it in, or can you pull it in and out? Does it make this nice wave motion as they're sucking on your finger, or are they just chomping on it or clicking it around? Is the roof of the mouth flat and smooth, or is it really high up? If you've got a really high palate, that's going to create a lot of airspace in there that makes it hard. We want to document and classify the tongue, and I love to utilize the Kotlow tongue classification. I think it's easy. I think it's simple. There's lots of other classification systems out there, and maybe in 5 years I might use a different one, but I really like this one, and it goes from a 1 to a 2 to a 3 to a 4, where 4 is kind of more severe and a 1 is less. Okay. Classification is very important that we're documenting these and we're talking about it, but we don't make a diagnosis based on the classification alone. Once again, we must put together symptomatic issues, functional issues, anatomical issues, and all of those put together create an indication for you. And that is a firm leg to stand on. Let's talk about treatment. Old school would be scissors or a scalpel. All right. Um, in an older child, what they would do is they surgically will grab the tongue and pull it up. They will notch out and cut out the frenum with scissors or with a scalpel, and then they'll suture it back together. That is not a wrong procedure, okay? That is still a very good surgical approach, but particularly for a baby, that is not applicable, okay, without putting them under full general anesthesia, okay? And why do we need to do that for a short, simple procedure, okay? Who wants to sign up for that? Nobody. Our new school way of doing this is going to be with laser technology. Okay. What I love to utilize in my practice is the BioLace Waterlace I Plus laser. It's an all tissue laser. It does both hard tissue and soft tissue. It's a water laser, so it helps cool the tissue. It's very minimally invasive. Okay. My referrals love this over the CO2. Right. They one of the reasons that they refer things to me is they like how it interacts with the tissue better. Okay. So once again, When we're looking at a laser, it is just a fancy flashlight. That is all it is, okay? How does it work? It's an erbium chromium laser, YSGG. It's attracted to water, okay? And so there's a lot of water in soft tissue, and so that's how it works so well, all right? What does it do? It heats the tissue up and it vaporizes it. Technically, that's called ablation, and this comes to you out of your AAPD reference manual. So this is something that is published for you in your pediatric literature, okay? How does this benefit the tissue, all right? When we're looking at tissue and surgeries, we are always inducing trauma by doing a surgery, okay? But the less trauma we can induce, the less necrosis or cell turnover or cell death we're gonna have. The water-based laser only induces about 5 to 10 cell layers of death, okay? A scalpel is about 100 to 300. Think about it as like layers of an onion. You literally just scratch the surface. The less damage you do, the less bleeding you're going to get, the less post-op inflammation, the less pain and discomfort, and the less scarring, okay? And the better healing, all right? Our laser is also not a cauterizing or burning laser, okay? A CO2 generates a lot of heat, and if you don't move it quickly, it's definitely going to burn the tissue. The diode is definitely going to burn and char the tissue, but the erbium YSGG does not, okay? I love this slide because it compares our laser, the water laser, and the amount of heat, okay? These CO2s, they work really well, they work really fast, but the amount of heat that they generate is so hot. Where our laser is very, very cool, it's very minimally invasive. And so what we see is normally we get healing within 1 to 2 weeks, okay? And so that is a lot faster than kind of the 3 to 4 to 6 weeks with other laser techniques, okay? When we're looking at an erbium laser versus a diode, you definitely get a lot more charring with those diodes than you would with an erbium, okay? What does it handpiece look like? It looks just like a high-speed handpiece, okay? It's got a little tip in it, it's got an aiming beam, it's got light, it sprays water, it has a little tip in there that you change out, it's lightweight, it's easy to use, it's autoclavable, it's very, very familiar, okay? It's not a burr. You're not touching the tissue and hacking away. You're working at about a 1 millimeter working length. It's very, very precise. What I love about that is if the baby moves, guess what? The laser doesn't work unless you're 1 millimeter away from the tissue, okay? So if the baby moves, nothing happens. If you're using other lasers that have a longer working length, okay, you might damage some other tissue structures. Or if they work really, really fast, okay, you might go too deep or too to the right or too to the left. With this laser, you're able to keep it very, very precise and effective and efficient, okay? I love it for those reasons for babies, okay? What does that mean for the patient, particularly for the babies? It's very safe and very precise, okay? What do we need to do for these babies? First, you take a picture. If you took nothing away from this, it's that you're going to start taking pictures, okay? Safety glasses. You need to wear safety glasses. The assistant needs to wear safety glasses. If the parent's in the room, they need to wear safety glasses, and the baby needs some sort of safety eye protection. You can get those little tanning bed glasses, or you can do infant laser eye patches, okay? Those are really simple to use. I like the eye patches because they adhere and they're not moving around as much like those tanning bed glasses. Why do you need to do that? For one, it's the standard of care. For two, it's safety, and you want to protect the eyes, okay? And you want to document that in your note that everybody in the room wore appropriate protective eyewear, okay? How do we stabilize the babies? I love these little lap boards, okay? I like to have where my assistant sits in the dental chair with her feet on the floor. I sit in my doctor's chair. We sit knee to knee. We've got suction. We've got gauze. We've got our retractors and everything ready, and we do it in our lap, okay? That is my favorite way of doing it. I love to use the big muslin swaddle blankets. I swaddled up all four of my babies in those muslin blankets. We have a washing machine here in the office. We just wash them afterwards. If we're not going to use a muslin blanket, these Ollie swaddles are super popular, super easy to use, and really great. I'm just partial to muslin blankets, okay? How do we position that baby? Once again, I want to be at 12 o'clock. I want my assistant to be at 6 o'clock. I want her to hold the chin and I want her to suction. Okay. I want her to get the spit and the little bit of water that's spraying in there out. It's not a lot of water. It's easily sucked out with a slow speed. Okay. If you've got a second assistant, that's great. They can hand you gauze. They can be there to help maybe stabilize the head, or they can take pictures for you while you're doing it. So a second set of hands in there from another assistant does make it a little easier. Okay. I do not like the parents in the room. And so for my babies, that's one of the only procedures in my office that I don't have parents back for. I have them wait in our lactation room. They're on opposite corners of the office, and I find that it's just easier for the parent that way. How do we control that crazy tongue? Old school was a suture, all right? You held up by a suture. We're going to use what's called a groove director. You can order these off of Amazon, and they're cheap and autoclavable. You put it under the base of the tongue and you lift it up, and it will easily isolate for you the frenum, okay? Do we numb? I am not a number, okay? For my under 12 months, I do not use any benzocaine, okay? Because we have to keep in mind that babies can have a reaction to what's called methemoglobinemia, where they have a delayed reaction where they stop breathing. And you are way more at risk for that when you're under 12 months using benzocaines and prilocaines, okay? I want you to realize that the FDA has a black box warning against benzocaines under the age of 2, okay? Lidocaine is a FDA black box warning for under the age of 6 months, okay? So if you're using any sort of those sorts of anesthetics in those ranges, you just want to know that the FDA definitely is not on board for that for you, okay? You are the doctor. You must make the best decision for you, okay? I would never tell you what to do, okay, or throw shade at you for what you do in that. But I want you to know those are the risks that you're assuming with that, okay? And you must make the decision for what is best for your patient. I do not feel like I'm a barbarian for doing this release without it. I feel like I'm actually an advocate for their care and safety, okay? Lingual frenectomies. Geez, let's dive into this treatment, y'all, okay? Where do we start? That is the first question I ask myself. Geez, where do I make my cut, okay? We are going to go below the groove director and above the salivary glands. Anatomical landmarks are key. I love for you to cut horizontal and not vertical. If you cut vertical, you might go up into the base of the tongue or down into the salivary glands. Going side to side is safe, okay? So where do we start? We're going to start in the middle, below the tongue and above the salivary glands, below the tongue groove director and above the salivary glands, and make your horizontal incision, okay? Where do you stop? You should normally see kind of a diamond-shaped incision here, and when you rub your finger over it, it should be nice and smooth, okay? So when you elevate it, we want to see all those deep fascial fibers are removed, okay? This is not a race, okay? I want you to take it slow and steady. You do not win a prize for doing this in 10 seconds. You do not win a prize for doing this in 1 minute. You do not win a prize for doing this in 2 minutes, okay? And so I'd rather you take multiple little stops. What I do is I lift the tongue, make my initial incision, and let go. I look at the tongue, I lift it up again, make another incision, let it go. Lift the tongue up again, make another incision, let it go. I do it in incrementals. It literally takes me 30 seconds, and then the release is done. But I always keep my landmarks in mind. A good surgeon always identifies their anatomical landmarks, okay? One of my pro tips for you is taking your finger and rubbing pressure under the tongue. That can be a good way to feel those fibers or to make sure it's nice and smooth, okay? So I'm always removing that under. Let's walk through a few cases here and then we'll open it up for questions, all right? You'll see that this baby has a very short anterior attachment that is almost like a heart shape or a forked tongue. When we lift this tongue up, we don't want to make it the incision here at the base of the groove director, or you're actually going to slice into the muscle of the tongue. This is going to be muscle. You do not make your incision down here at the base of the mandible, or you will run into the floor of the mouth and the salivary glands. You need to make the release where the fascia is, which is superior to the floor of the mouth and inferior to the base of the tongue. When you make your incision, you normally end up with this classic diamond shape and maybe a little bit of bleeding. What you will not end up with is charring, okay? It is okay to have a little bit of bleeding. We do not want to have charring, okay? This is a case where the baby had an anterior attached tongue and the mother had severe maternal nipple pain. Both the pediatrician and the lactation consultant were concerned about a tongue pie but did not refer. This was the mom's second baby. She breastfed the first one like a champ, but this one struggled and struggled and struggled and struggled for 3 weeks, and she knew that there was something wrong. She brought the baby to us. We released the tongue, and immediately afterwards, she breastfed like a champ. She cried tears of joy. Do you think she loves her pediatrician? No. Okay. She was quite upset with them because they did not listen to her. Okay. She knew there was a problem. She knew her baby was struggling. She was crying tears of joy because finally someone listened. That can be you. All right. Take post-op pictures, not just pre-op, but post-surgical pictures. Before I lean that baby up, I take pictures so I can show the parents what they're working with, okay? This is immediately post-release. This is 1 week follow-up. I see every baby back for 1 week because I want to check in on how symptoms are improving and how the frenectomy area is healing, how the surgical site is doing. You will normally at 1 week see a white to yellow fibrin scab and the wound is closing. This is pretty classic for what we see at 1 week when we're using a water lace, okay? When we're using other lasers, it's gonna look a little bit different and healing is gonna be a little bit more delayed, okay? But this is pretty rapid healing, okay? What I want you to think about again is that you're gonna do the best you can until you can do better. When you know better, do better. I hope that you saw walking through this that there are better ways to look at it, better ways to think about it, better ways to document it, and better ways to take care of these babies. Those babies need you. You'll notice at the bottom of all the slides, I put propaganda down there because I believe you never stop learning so that you can do good and you can better serve the patients in your community. You learn, you do, you serve. We make a living by what we get, but we make a life by what we give. These babies need you to take care of them. Think about this baby. I want you to think about her. This baby lives in my community. I actually saw her last Saturday in my daughter's basketball game. She is now into toddlerhood and she's doing so good. When I see her, I think about all the good that we can do in our profession to help those babies. Where would that baby have been if it wasn't for us taking care of them? You can make a difference, okay? I want you to also make sure that you go and seek out the Waterlace educational resources, okay? There's a whole list, a whole manifesto of resources for you, of online webinars that are free and available to you at the touch of a mouse click, okay? And so if there's something you've got a question about, there's probably a webinar for it. And I hope to see each 121 of you, all right, that are on here today at Tequila and Tongue Tie in Miami. We are going to have a great time with great CE, with great speakers coming to you from across the nation that are there to help you better serve those kids in your community. And we're going to have a fun time while doing it. All right. Here's my information, my email, my social media accounts. I run my own social media accounts. So if you message me on there, I will get back to you. That is me. Go look on there. I did a great post about lips, okay, and lip ties and what those can look like externally, okay? I post a lot of great cases on there that I see for myself within my practice, so know that those resources are there for you, okay? Thank y'all for tuning in. We're going to open it up for Q&A, guys, okay? We've got a couple of questions in here, and I want you to keep putting them in there, okay? We're going to start through these, and we'll work through them, but I want you to go ahead and start popping those questions in there, and we'll work through those, okay?
All right. Thank you, Dr. Curtis.
Yeah, Joe.
All right. Let's take a look at some questions. And to the audience, I know Dr. Curtis mentioned tequila and tongue ties. And here in a minute, when we're done with questions, I do have some information to the audience about the types of speaking topics that we'll have at the event. So just bear with us, and we'll get to that here in a second. If you don't mind, Dr. Curtis, I'll help moderate some of these questions here for you. The first question was, which I think resonates with you. We have a doctor from a more rural area, and they're asking about, if they don't have access to myofunctional therapists, what recommended exercises do you give to your patients?
That is a great question because I come from a very rural area where you may be over an hour or more from a specialist like that. And you may not have the monetary resources to drive there or the monetary resources to actually afford that sort of specialty care. And one of the things I would say is we try to help them in that and be able to provide, what sort of resources we can as far as functional stretches and tongue positioning and things like that. We normally recommend for them to actually seek one, no matter where they are. We'll give them the referral for those. But I also want us to think about that you can do these via Zoom too. Okay. And so some of these therapists will actually do it via Zoom so that they can actually access you without actually having to be there physically. And so Zoom has actually opened up a lot of doors for that. So even if you don't have one, let's say within an hour of you, you might have one that is able, no matter if they could be in California and you could be in New York, and they might be able to actually Zoom with that patient and do it over Zoom for them as well. So I don't want you to be restricted to your geographical location with that, but I also don't want that to be a barrier for that patient seeking care. Okay. We in rural communities understand that our patients may not be able to have all the access to all those things, but they still deserve care. Okay. So I love that you're an advocate for them in that. And I'd also pitch to you that at Tequila and Tongue Tie, we're going to be talking about myofunctional therapy and how you can help integrate that into your office. And I'm bringing some of my staff members there because I think that's important for them to hear as well. So hopefully, maybe we'll see you there and you'll be able to learn some more about that too.
Great. The second, there's a couple questions about vitamin K. You spoke about vitamin K earlier in your lecture. So I'll kind of bundle these into one question, but how do you answer the question on vitamin K with parents who opt not to get it for their baby?
So I actually see quite a bit of crunchy or holistic parents in my practice as well. And I am known for doing releases on parents that don't do vitamin K. So I do see quite a bit of those. And really where we want to be thinking about that is these parents are assuming a risk. And we just want them to understand that they're assuming that risk by not doing vitamin K. We want to be documenting that. We want to be consenting for that. We want to be talking about that. And so, just because your choice of not doing vitamin K, you as a doctor have to make the choice on whether you want to have that release in your office or you want to require them to get vitamin K or that you don't want to do it until a certain age without vitamin K. Okay. Vitamin K is a coagulating factor. And so we know once they have vitamin K shot on board that they're going to have a much higher coagulation potential and a lower bleeding risk. If they don't have a vitamin K shot, they're going to be at a higher bleeding risk, but that bleeding risk is actually not an immediate risk, it's a delayed risk. So the conversation I have with the family goes like this. I see that you didn't check that you opted out of vitamin K. Is that correct? Normally the parents that check no, I always have them verbally confirm that they have not gotten vitamin K because there might be an equal amount of them that didn't understand what vitamin K was. They had their child at a hospital and they didn't elect out of it, and that they actually were just confused by the question and they did get vitamin K. So I always verbally confirm that with them and they'll know if they elected out of it. They signed a form. Okay, so that's step one. Step two is I inform them that your child is actually at a higher risk for bleeding because they didn't do vitamin K. Vitamin K is a coagulation factor that helps that. I want you to understand that that is why it is normally recommended at birth and that your child is going to be having a surgical procedure that vitamin K would help with coagulation. I can appreciate that you might not have thought that your child was going to need that or have a surgical procedure so they weren't at elevated bleeding risk, but your child now, by assuming a surgical procedure, will be at a higher risk for bleeding. So we have a few options. You can proceed with the procedure and have that, and you assume the bleeding risk, meaning that we'll make sure the bleeding is great before you leave. But within the first few hours, you may find that the bleeding resumes, okay? And that you would thus need to take your child to the emergency room, inform them that you had a release, and that they will then need to provide coagulation factor for your child, okay? That's one option. Option two is that we can go home and think more about it and you can elect into a vitamin K shot. Within 24 hours after that, you'll be able to come back next day and we can perform the release and your child will thus have a heightened amount of coagulation factors. If you choose to do vitamin K drops, it is not the same as effectiveness as a vitamin K shot. And so it does take about a month or so of those drops to be able to get your child to the level of vitamin K where you'd feel more comfortable with that. And so if we're going to elect for vitamin K shots to get to that full amount of coagulation, we need to delay treatment for a month at least, okay? So those are normally the options I provide the parent with. We document those in the chart and we document what the parent chose and we move forward with the procedure. Okay. If they've elected out of that, we're normally following up with them later that day or the next day, just to make sure that they're doing well. Okay. That's my vitamin K in a nutshell.
Yeah, very good. There's quite a few questions, Dr. Curtis, about, and I'm sure these are coming from our current Waterlase dentists that are asking specifically about, what settings you use, what
Yeah.
tip you prefer to use for this procedure. So do you mind just reviewing real quick with the Waterlase what tips and settings you prefer for the procedure?
I love to use an MZ5 or an MZ6. So an MZ5-6, so the 6 millimeter length, or an MZ6-6, 6 millimeter length. I love that one because I like the amount of energy that comes out of that. You could use an MC3 chisel, which is the one where you can touch the tissue, but I don't like that as much because it's a little bit more conservative in the power, and so you have to kind of like cut more, okay? I will normally use the frenectomy setting for frenectomy rapid setting for a thin one. If I have a really thick, beefy, like fibrous one, I'll move it up. And I actually don't mess with the settings at all. What I do is go into, brace yourself, into the composite setting, into the class 1 comfort prep, and I will do it on a class 1 comfort prep setting. So it's a little bit more power and it'll cut through that a lot more efficiently and quicker for you. Once again, at that 1 to 2 millimeter working length for the really thick, tight ones, that'll help blow through that a lot quicker for you. But you want to make sure you're not using a bigger tip. You want to make sure you're staying with a smaller tip, and you want to make sure that you're not bumping it up to any more energy than that. But that'll help you go through those really, really thick ones a lot quicker. Okay. And then let's say if we're having some bleeding or a little bit of kind of issues with that, we can go over it with a laser bandage setting, which once again lives under the frenectomy setting. And you can just click laser bandage, and I like to do it dry. Okay. And you can go over the laser bandage with that. Do I laser bandage every one of them? No, just the ones that might have like a little bit more bleeding in that. If I get one that has quite a bit of like, I'm like, oh man, that's kind of bleeding a lot. What I normally do is I will just sit the baby up and I take a tiny, like, a popsicle, break off part of a popsicle and wrap it in gauze and just hold it in there and let the baby calm down. They eat a little bit of sugar, they get the cold pressure from that, and they calm down, and that'll help. What you need is the blood pressure and the heart rate to go down, and then normally it'll easily coagulate from there. So I normally just stop messing with it and let the baby just chill out, and that will normally take care of that for you too. Okay. But I like that
Perfect.
MZ6.
MZ5 and MZ6. And we did have a couple questions, additional questions about myofunctional therapy. I did want to highlight for the audience that I'll review here in a second as we close out. We have a myofunctional webinar coming up in March. And so I'll review that with you, and that would be a great webinar to join us and ask our expert, Megan Van Noy is her name, on that webinar, specific questions about myofunctional therapy. And so I'll review that here in a second. I did get a question about, what's that name again for the tool you use to hold up the tongue? And that was Groove Director, correct?
Groove Director.
So that's Groove, to that audience member, that's Groove Director. You can just put that in the search box in Amazon and they'll pop up and you can order it easily there. And then one of the final questions before we get into closing out our session, we did get a question about any additional tips, to stay away from sensitive anatomical structures in the floor of the mouth. I've watched you quite a bit, Dr. Curtis, in courses. I know you really focus on this in your classroom courses. So I did want to mention this, this question, because I know it's important to highlight before we wrap up.
That is a very important question. I cannot highlight enough for you that you need to make sure you keep clear anatomical landmarks, okay? And so that is key to a successful release, okay? What I'll mention is what I am never worried about meaning like it doesn't stress me, are the vessels, okay? You can see a blood vessel coming, all right? You'll see something like a major artery, a major vein, small arterioles. You'll see those before you get to them. What you will not see are the salivary glands, okay? So it is important to make sure you're always conscious of where the salivary glands are, because you could easily cut through the salivary glands because they're clear, they don't bleed, and what they release is clear. And so I want you anatomically to make sure you are always superior to the salivary glands. The deeper you go back into the base of the tongue, making sure that you are always superior to the salivary glands. If you will make an incremental incision, one at a time, release, let go, release, let go, release, let go. And each time you lift the tongue up, notice where the base of the tongue is and where the salivary glands are. You will make your release in the proper area, okay? If you see brown, turn around. You are in a muscle, okay? It should not be brown. You are in the base of the tongue, okay? If you are seeing a lot of clear liquid, you need to brace and stop because you may be in a salivary gland, okay? We want to make sure that we are keeping a very clean site. And so I'm not as worried for myself and for you about major vessels, okay? Like blood vessels, all right? That's what you think you're worried about. But what we need to make sure that we're keeping in mind are the salivary glands, okay? Joe's right. I talk about this and I talk about this and I talk about this in my courses all the time because anatomy is key. Thanks, Joe, for highlighting that.
Perfect. And to our audience, we are out of time for our session this evening. I wanted to remind you that we have part 2 coming up. Some of your questions were related to adolescents and older children. So we can definitely address some of those questions and may do it naturally during Dr. Curtis's lecture coming up on March 5th. So I do apologize. We don't have time to get through all the questions, but luckily we do have another session coming up here shortly. As we start to close, I did want to let the audience members know how you can register for tequila and tongue ties. Now, the next slide, I will go through the topics that we will be discussing at the conference. It's April 19th through 20th in Miami. Just type in your search engine tequilaandtongueties.com and you can find all the information you need from the agenda items to the hotel and the venue to go ahead and register yourself and your staff to come. So again, tequilaandtongueties.com is where you'll find information on our conference. Okay, these are the main lectures that will be at the conference this year. Dr. Curtis will be kicking off the lecture with the wonders of water lays, why the erbium chromium YSGD laser is so good at frenectomy. So he'll be taking a deeper dive into some of the content he's teed up this evening. Our good friend Dr. Cherish Learn will be talking about tips to improve outcomes. Dr. Amanda Hankins out of Arkansas will be going through a step-by-step review of the protocol she uses for the frenectomy procedure. For the second year, we'll have Allison Lecoussier speaking on social media and how to properly promote technologies that you're using in your practice through social media. That should be a fun session. And then the last two, Dr. Austin McMurphy out of Southern Mississippi, a good friend of ours, will be joining us to talk about how his laser has really revolutionized his practice. He's doing fantastic work in the state of Mississippi, pulling in a lot of people that are needing his services with his laser technology. So he'll be speaking of that. And then lastly, myofunctional, big topic. We'll be spending 2 hours on myofunctional therapy on that Saturday of the conference with Megan Van Noy. And Megan will be our speaker coming up on our late March, we'll get to the specific date here in a second, her late March national webinar that we'll be hosting. For additional education resources, just go to biolace.com, click on education, and you'll find Waterlays Academy that Dr. Curtis spoke about. That's where you'll find all sorts of courses and content, webinars, you name it. The one course I wanted to promote to our audience is by Dr. Rashida Jaju in Northern Virginia. She opens up her office a couple of times per year and brings in doctors to show them firsthand how she works with her patients, her workflow, everything that she does in her wonderful practice there in Reston, Virginia. That course is in her office on March 7th and March 8th. Any additional information you need from us on the education team, please email us at education@biolase.com, but that's a great course that's coming up. Okay, last two things. Part 2, Dr. Curtis will be back Thursday, March 5th to talk more about this important issue. Please come back and throw these questions back in the chat, and I promise we'll get to them. So excited to have Dr. Curtis back on March 5th. And then March 21st, that's the date that I could not think of a second ago. So March 21st is our myofunctional therapy webinar. So a great ending to our series here and a great tee up for our tequila and tongue ties lecture at that event. So please join us on March 21st. Okay, that is it. So again, you will get CE for joining us. You must be registered, and attendance will be recorded via Zoom. The most important thing I want you to know before you leave us is you'll get a survey email from our education team. You got to complete that survey to get your CE certificate. So get the survey, complete it, then you'll get your CE certificate for the 1 CEU for this evening. Again, thank you so much for joining us. Dr. Curtis, wonderful content and lecture. I always learn a little something from you when you lecture, and I love your passion and always love working with you. So thank you for joining us, and looking forward for you coming back on March 5th.
Yeah, and I'll put one final plug in, Joe. You know, we've been talking about all the great CE you're going to get at Tequila and Tongue Tie, but there's an awesome dinner party with a DJ and a tequila tasting as well, like a tequila happy hour. So you're going to have fun as well as having good CE. So you better be there.
That's right. So we do sprinkle in a little fun. It's okay to have fun as well as learn. So we hope you join us. Anything you need from the education team at Biolase, again, that email address is education@biolase.com. Please send us your questions or anything you need from us, and we'll be sure to respond to you. Have a great rest of your day or evening, wherever you're coming from, and we will see you hopefully on March 5th. Thank you so much. Thank you, Dr. Curtis.